Welcome to the Roundtable on Obesity Solutions webinar, The Potential Role of Nutrition in the First 2 Years of Life in the Prevention of Child Overweight and Obesity. Thank you for tuning in today. My name is Kay Dewey, and I am a member of the Webinar Planning Committee. I am Distinguished Professor Emerita in the Department of Nutrition at the University of California, Davis. My research focuses on maternal and child nutrition in both low-income and higher-income populations in the United States, Latin America, Africa, and South Asia. In the past, I have served as president of the Society for International Nutrition Research and of the International Society for Research on Human Milk and Lactation. I am currently a member of the board of the Global Alliance for Improved Nutrition, of the Food and Nutrition Board for the National Academy of Medicine, and of the 2020 Dietary Guidelines Advisory Committee. I want to take a moment to recognize and thank the other members of the webinar working group, Anne Dattilo from Nestle Nutrition, Heather Hamner from the U.S. Centers for Disease Control and Prevention, and Mary Story from Duke University. Next slide. First, I would like to provide some background on the work of the Roundtable on Obesity Solutions. The Roundtable engages leaders from multiple sectors to foster ongoing dialogue about critical and emerging issues in accelerating and sustaining progress in obesity prevention, treatment, and weight maintenance, with special attention on effective health equity strategies for addressing obesity-related disparities. This webinar will focus on the role of infant and early childhood nutrition with respect to healthy growth and prevention of overweight and obesity later in childhood. It will build on previous Roundtable efforts which focused on obesity in children ages 0 to 5 years and the current understanding of pre-pregnancy weight gain. Those two reports, Obesity in the Early Childhood Years and Weight Gain During Pregnancy, as well as the webinar from 2018, The Current Understanding of Pre-Pregnancy Weight, Gestational Weight Gain, and the Impacts of Maternal and Child Health Among Women with Obesity, informed the work of this webinar's working group. Next slide. Today, Cynthia Ogden, Bill Dietz, Elsie DeVeris, and I will be speaking with you about current prevalence and trends of high weight for length among infants and young children, the state of the science on modifiable risk factors, prevention interventions for infants and young children that address healthy growth, and how these can be viewed through an equity lens. These presentations will be followed by an audience question and answer period. Please type your questions into the Q&A box at the bottom of your screen at any time during the webinar, and I will share these with the presenters during the discussion. Just a few quick things before we get started. The audio for today's event will be streamed through your computer speakers. This webinar is being recorded. A link to the recording as well as a copy of the slides will be posted on the Roundtable's website within the next week or so. If you have any technical issues during the event, please contact Zoom technical support at 1-888-799-9666, extension 2. Again, that's 1-888-799-9666, extension 2. Next slide. First, we will hear from Dr. Cynthia Ogden. Dr. Ogden is an epidemiologist and chief of the analysis branch in the National Health and Nutrition Examination Survey Division at National Center for Health Statistics, Centers for Disease Control and Prevention. Over a 2-decade career at CDC, Dr. Ogden has become an internationally recognized expert in nutritional and obesity epidemiology. As a member of the team that developed the 2000 CDC pediatric growth charts that are used to define obesity in U.S. children, she led the evaluation of the charts. She is currently an adjunct professor at the George Washington University Milken Institute School of Public Health. Welcome, Dr. Ogden.
Thanks so much, Kay. As Kay mentioned, I am going to be talking about current prevalence and trends of high weight for length in infants and young children in the United States. Next slide, please. This age group is really among the hardest in terms of descriptive epidemiology and obesity. Next slide, please. There are two of the reasons why it's a challenge to do descriptive epi in this age group in infants and young children or toddlers are related to measurement and definitions, and then the availability of data. So let's start with measurement and definitions. Next slide, please. Next slide, please. As you know, when in doing assessments of weight and weight for length in young children, measurement of recumbent length needs to be conducted, and that can be a challenge. And this is in contrast to, next slide, please, standing height, which happens at about age 2. So up until age 2, recumbent length is measured, and then starting at age 2, standing height is measured. Next slide, please. There's a difference between a recumbent length measure and a standing height measure on the same individual. And the difference it depends on the data set or on the way the measurements are conducted. And for example, in the CDC growth chart data, there's about a 0.8 centimeter difference between length and standing height on average when measurements were conducted on the same individuals. Next slide, please. The definitions of excess weight in infants and toddlers compared to older children are different. And this slide shows the definitions of the birth to 5 years in the United States. And you can see in the first column for the birth to 24 months or infants and toddlers, the indicator used is weight for length. The reference population is the WHO growth charts, and the cutoff for high weight for length is 2 standard deviations, or the 97.7th percentile. As we move to older children, a lot of things changes, and so this is important when you think about looking over time at a child or comparing, doing cross-sectional stuff, looking at younger versus older children. We move to BMI for age, which is kilograms over meters squared, and we use the CDC growth charts as the reference population, and the cutoff for obesity now is the 95th percentile. Severe obesity is 120% of the 95th percentile. So there are a lot of changes that happen at age 2. Next slide, please. As I talked about before, we look at recumbent length or standing height, and so measurements are conducted to look at excess weight in infants and toddlers or high weight for length. Next slide, please. But sometimes in studies, questions are asked about recalling a child's weight or height. Next slide, please. And there's a difference between measuring and asking. And in general, it's much better to measure. So this slide shows the prevalence of obesity in 2 to 3-year-olds in the U.S. population at the same point in time based on 2 different national surveys, one that has measurements and one that has parent or proxy report of weight and height. And you can see a big difference. The measured data, the prevalence is about 8% in the 2 to 3-year-olds versus the proxy reported data is 44.7%. Next slide, please. And that's primarily due to underreport of height. And so this just shows you the importance of measuring over asking. Next slide, please. A measurement, I spent a lot of time thinking about measurement. So measurement is really important, and being careful to do precise measurements, especially in infants and toddlers, is very important. You can see in this table that a small change in weight or a measurement error can lead to a change in the category of weight for length. And so this is a table for boys who are 60 centimeters long or 23.6 inches. And you can see changes in weight and then the changes in the percentile based on the WHO weight for length growth charts. And you can see that just a half a pound difference can move a boy from the 95th to the cutoff for excess weight for height. So precise measurements are very important. Next slide, please. Then another area that can make it challenging to do a descriptive epi on infants and toddlers are in the United States are data sources available. Next slide, please. The primary data source for obesity estimates in the United States is the National Health and Nutrition Examination Survey, or NHANES. It's a nationally representative survey with exam data, about 10,000 overall, the number of participants, each 2-year cycle. In 1999, the survey became a continuous survey with release every 2 years, but prior to that, there were periodic surveys. So there were some surveys before that back into the 60s and 70s. Next slide, please. In relation to infants and toddlers, NHANES has a very small sample size. So from birth to 24 months, the sample size every 2 years is about 600. And for birth to 2 months, it's only about 75. So it's very important in doing analyses with NHANES data. If you really want to look at subgroups, you've got to combine more than combine cycles together so that you might have 4-year estimate or maybe even a 6-year estimate. Next slide, please. This is a picture of the mobile exam centers for NHANES that travel around the country. And just to emphasize that the measurements in NHANES are standardized measurements taken in these mobile exam centers. And you can see that there are quite a few trailers. And so there are a lot more exams that are conducted in the trailers besides measurement of weight and height. Next slide, please. Another source of information or data on infants and toddlers in terms of excess weight or high weight for length is our data from the WIC program, the Special Supplemental Nutrition Program for Women, Infants, and Children. And these data would reflect the prevalence then of low-income children. Next slide, please. So let's look at some data, some results from these two data sources. Next slide, please. The most recent data from NHANES are from 2015-16, and they show that among infants and toddlers, 8.9% have high weight for length, and 13.9% of preschoolers have obesity. Next slide, please. NHANES, we can look at changes in median weight across the NHANES surveys. And as I mentioned, in 1999, NHANES became continuous, but there were some periodic surveys before that. So this graph shows infant girls, and it goes back to, in light blue, the 1988-94, and that starts at 3 months of age. So we can look at 4 age groups: birth to 2 months, 3 to 5, 6 to 8, and 9 to 11 months. And you can look across time, and you can see that there's been very little change, if any, in median weight among infant girls across this time period from 1988 through 2014. And as you may recall, a median is the 50th percentile, which means that 50% of infant girls in that age range had a weight below that point, and 50% had a weight higher than that. Next slide, please. This is a similar graph, but looking at median length among infant girls over the same time period, the same age groups, birth to 2 months, 3 to 5, 6 to 8, and 9 to 11 months. And again, really no change across the time periods in median length among infant girls. And the graphs, we could do similar graphs for boys, and they show a similar pattern. Next slide, please. This is now, we wanted to look at, well, how does it look as kids get a little bit older? And so we're looking now at 1 through 10 years of age. And this is girls still. And this is going back to the late 1970s because we have data back to 1 year of age back into the 1970s through 2011-14. And you'll notice that it's combined data for 4 years of data, so we can get a better estimate for each age group. And this is looking at the 50th percentile, the median, and the 95th percentile, and that you can see that there's been a change, and that the absolute increase between the two time periods increases with age. And so that's what this graph shows. You can see a bigger difference between the red and green lines at age 10 than you do at age 1. Next slide, please. This is looking at the same thing, but actually looking at the percentage change or between the two time periods by age. And really the percentage has also, the absolute value of the increase has changed by age, but so has the percentage. So that there was about a 3% increase at age 3 in both the median or 50th percentile and the 95th percentile. But by age 10, there was a 12% increase over time in the median weight of girls, and a 27% increase in the 95th percentile between the 1970s, the late 1970s, and 2011-14. So there's an absolute increase over time, and there's a percentage-wise increase by age. Next slide, please. If we look at trends in high weight for length between the late 1970s and 2011-14 in the United States among infants and toddlers 6 to 24 months of age, we see that there's been no significant trend. And you can see the confidence intervals around each of the estimates, and they're relatively tight. Next slide, please. We can also look at trends by race ethnicity from 1988 to 1994 to 2011 to 2014 by race, as I mentioned, race Hispanic origin among 6 to 24 months. And there's been no significant change here either. You can see wider confidence intervals because there are smaller sample sizes, and you see more noise, if you will, or jumping around of the estimates, and again, because there are smaller sample sizes because we're looking at a subgroup. Next slide, please. This is probably the most complicated slide I'll show, and this is looking at race ethnic differences in trends of relative weight gain from birth in 1988-94, the earliest point there on the left, through 2011-14. And the only increase was in non-Hispanic Black children, 6 to 24 months, and this is only among normal birth weight infants. And this is adjusting for birth weight and for age at the actual measurement. And so that's what it means to say relative weight gain. And so, as I said, only among non-Hispanic Black children was there an increase, and it was of about 240 grams. Next slide, please. If we look at data from 2011 to 2012 among infants and toddlers in the United States, there's no difference, no significant difference, I should say, by race Hispanic origin in high weight for length. And you can see here a bar chart that looks at non-Hispanic whites, non-Hispanic Blacks, non-Hispanic Asians, and Hispanic youth. And there's a very wide confidence interval around non-Hispanic Asian children because the sample size is small. Next slide, please. This is in contrast, the last slide is in contrast to the prevalence of obesity, and this is among 2 to 5-year-old children in 2013-16. And you can see in this case, the prevalence of obesity is higher among Hispanic children than among non-Hispanic white and non-Hispanic Asian children. So there was no significant difference among the infants and toddlers, but there is a significant difference among the 2 to 5-year-olds. Next slide, please. If we compare the U.S. estimates from N. Haynes to the prevalence of high weight for length in the WIC population, we see that the prevalence is higher in the WIC population than it is in the general U.S. population. And this slide in green is the U.S. data from 2014 and the WIC data from 2014 to be comparable in terms of time. So 8.1 versus 12.3%. And that's a significant difference. It's significantly higher in the WIC population. Next slide, please. If we look at race-ethnic specific differences between the U.S. data and the WIC data for non-Hispanic white and non-Hispanic blacks, the only groups that we have enough sample size to do that for, we can see the same pattern as we saw overall in the last slide, that the prevalence is higher in the WIC population than in non-Hispanic whites or non-Hispanic blacks in the general population. Next slide, please. We have seen a decrease in high weight for length in WIC participants birth to 24 months of age, and that's true, and that was between 2010 and 2014. And this graph shows the trends between 2000 and 2014 by race ethnicity, and you can see the biggest declines were in American Indian, Alaska Native, Hispanic, and Asian Pacific Islander children. Next slide, please. So to kind of circle back, and what are the main points I wanted to make in showing you all these graphs? There are a couple of methodological notes that I want to reiterate for this age group of infants and toddlers. That measurement and careful measurement is really important, and small measurement errors can impact categorization. So it's important to have precise measurements. There can be a challenge because of the so much switches at age 2. So when you're looking over time at children or comparing children at younger and older ages, even cross-sectionally, there's a change from weight for length to BMI for age. There's a change in the reference population, and there's a change in the cut points. And then we have a limitation in the small sample sizes that are available in the national and Haynes data to look at the general population in the United States. Next slide, please. If we look at disparities in infants and toddlers, in using the Haynes data, there was no significant difference by race and Hispanic origin in the U.S. population, but the prevalence is higher in WIC participants than it is in the general U.S. population among infants and toddlers. Next slide, please. And finally, this is looking at trends in, among infants and toddlers. There were no significant trends in high weight for length in the United States from the late 1970s until 2014. But there has been a recent decrease in high weight for length among WIC participants. Next slide, please. Thanks very much.
Thank you very much, Cynthia. Next, we will hear from Dr. Bill Dietz. Dr. Dietz is a consultant to the Roundtable on Obesity Solutions and chair of the Sumner M. Redstone Global Center on Prevention and Wellness at the Milken Institute School of Public Health at the George Washington University. He was director of the Division of Nutrition, Physical Activity, and Obesity in the Center for Chronic Disease Prevention and Health Promotion at the Centers for Disease Control and Prevention from 1997 to 2012. Prior to his appointment to the CDC, he was a professor of pediatrics at the Tufts University School of Medicine and director of clinical nutrition at the Floating Hospital of New England Medical Center Hospitals. Dr. Dietz has been a counselor and past president of the American Society for Clinical Nutrition and past president of the North American Association for the Study of Obesity. Welcome, Dr. Dietz.
Thank you, Kay. So despite the data that Cynthia showed you about the lack of changes in weight for height in the first 2 years of life, it's important to recognize that factors that operate in the first 2 years of life are a predictor potentially of subsequent obesity, as she showed the obesity increases in the 2 to 5 year olds. Next slide, please. So this is a broad outline of what I will discuss. I'm not going to spend a lot of time on the left side of this slide, but there are maternal factors during pregnancy which affect the subsequent BMI, such as pre-pregnant BMI, excessive weight gain, diabetes of all types, and tobacco use. I'm also not going to talk about these other factors, although Elsie will come back to the effect of sleep. But these factors on the right, food delivery and food composition, have been shown to affect the growth trajectory, and that's where I'm going to focus. So the next slide, please. It's important to recognize that the rate of weight gain in early childhood is a predictor of subsequent obesity. And this is a classic study that shows the result from a meta-analysis of 10 international cohorts, studies of almost 48,000 participants. And you can see on the left side that the odds ratio for childhood obesity by infant weight and gain during the first year of life are predictors of the subsequent obesity. And obesity in this study was measured in childhood from 6-year-old to 14-year-olds. And the risk is particularly high for that 21% of infants with very rapid weight gain who in this category are equivalent to the upward centile crossing of 2 or more bands. Next slide, please. One of the classic studies in this area is the childhood obesity study, which was a European multi-center double-blind randomized trial in 5 countries. And this took infants who were exclusively formula fed at 8 weeks of life and continued formula feeding up until the first year of life. You can see here the sample sizes and the amount of protein in terms of the percentage of energy. And these were compared with an observational group of infants who were breastfed exclusively until 4 months of age with follow-ups at periodic intervals during the first year of life. And was an additional follow-up of these subjects at 6 years of age. And in all of these, the slide that I'm going to show you next, these are measured heights and weights, not self-reported, so they have some validity. The other thing that's important to mention here is that this lower protein diet or formula has direct applicability to the formulas that children are fed in the United States. It's about 2 to 2.2 grams of protein. And as you'll see in the next slide, even the low protein has an impact on increasing the prevalence of weight for length. So in this slide on the left is the 0 to 2-year-old study. And at the top line, that kind of gray line, shows you the impact of the higher protein intake. The middle line is the lower protein intake, and the bottom line are children who are breastfed. And you can see here that the Z-scores of both weight for length and BMI follow the same trajectory. So increased protein intake in the first year of life is a risk factor for increased BMI and increased weight for length. On the right-hand slide, you can see the 6-year follow-up. And again, at the upper level is the higher protein, that the triangular solid lines. The gray lines are lower protein, and the gray lines are breastfed. And those differences that we saw in the first 2 years of life for the lower protein disappear, but there continues to be a higher risk for children who received the higher dose of protein. Next slide, please. And there's a reasonable potential mechanism for how early protein intakes can affect subsequent weight. That protein increases insulin-genic amino acids, which increase insulin and IGF-1, which increase weight gain and increase fat deposition, and therefore are risk factors for later obesity and chronic diseases. One of the other factors in breast milk, which has a role in perhaps protecting breastfed infants, is the presence of glutamate, which is a free amino acid in breast milk. And there has been a study which Elsie will consider that shows that glutamate is a regulator of satiety and associated with a lower incidence or prevalence of obesity. I'm going to turn now to, in the next slide, to another study. This is the Feeding Infants and Toddlers Study 2016. This replicated FITS studies in 2002, 2008. And you can see here the composition of the study. This study oversampled children in 0 to 24 months. About 2,500 of these children were in that category, with a reasonable distribution across ethnicity, although the Hispanic population was below what the national estimates are. Pretty evenly split between boys and girls. The caregivers were underrepresented with a high school GED, but there were questions similar to FITS 2002 and 2008, which allows us to compare across these studies. The dietary data were collected from a 24-hour recall, which was repeated in 20% of 25% of children. Next slide, please. So the first thing is that when we looked at infants who were ever consuming breast milk, there was a pretty stable initiation of breastfeeding over time. But one of the encouraging findings was that breastfeeding and the duration of breastfeeding increased over the same period. So that in the 2016 study, some infants, 55% of infants, were still being breastfed, although not exclusively, at 4 to 5.9 months of age. The other piece that is worth mentioning here is that there has been a study which showed that regardless of the milk in the bottle, whether it was breast milk or formula, that children who were bottle fed tended to have a higher rate of weight gain than children who were exclusively breastfed. But even under those circumstances, infants who were fed any breast milk had a lower rate of excess weight gain. Next slide. The other thing to know about formula feeding is that formula feeding is a marker for some other factors that are potentially contributory to the development of obesity in later life. And as we show here, there's an increased likelihood of infants who were formula fed consuming complementary foods at a very early age. In the 0 to 4 month period, 27% of infants were getting a complementary food, and I've shown here at the top that cereal, meat, fruit, or vegetable puree, and that rose to 85% at 4 to 5.9 months of age. Cow's milk, next slide please. Cow's milk is also a concern, not the least of which is because of cow's milk allergy, but also because the protein content of cow's milk is about 5.4 grams per 100 calories. And you can see here that there's a very low level of the introduction of cow's milk up until about 9 months of age, but then it bumps to about 17%. And that hasn't changed very much over the 3 FIT studies from 2002, 2008 to 2016. So it's in addition to the effect of cow's milk protein on gastric bleeding in infants, this is, I think, another potential risk factor for the development of obesity. Cynthia mentioned the WIC population, and in the next slide, I want to go back to the study that she mentioned. So, as Cynthia mentioned, and as you can see in this slide, there were big decreases in the prevalence of obesity in WIC population between 2010 and 2012. And that occurred regardless of the age that I'm showing here. And as Cynthia pointed out, there were major declines in children in minority populations, in American Indians, Alaskan Natives, in Hispanics, and African Americans. And what's unique about that finding is that most of the studies of interventions in infants and children have shown greater decreases in the white population than decreases in minority populations, as this showed. And as Cynthia mentioned, there were major changes in the WIC package in 2010. And those are shown here on the right side of this slide. So, no, back please, thank you. That the group, that there was a substitution of 1% milk and less of a milk allocation that for WIC recipients. That was about 7,500 calories per month. There was a decrease in the juice allocation, which accounted for about 1,400 calories per month. Which amounted to about 9,000 calories per month, or 200, almost 300 calories per day, more than enough to account for these decreases. The other factor that really should be mentioned, and is in this article that you see referenced here by Chaparro, is that there were also increases in the fully breastfeeding package, which may have contributed to the declines that you see here. Next slide, please. Consumption of sugary drinks we know is a risk for obesity in older children. It's also a concern that about 14% of children are consuming. Actually, this is 2000. The orange bars here are the 2016, and you can see that in the 9 to 12 month old group, there was a 14%, a 6% increase. In these 8 years since the study was done, but an even greater increase among the 12 to 14.9 months old. And as the next slide shows, we know that sugary drink intake in infancy is a risk factor for subsequent obesity. These are data from the Infant Feeding Practice Survey, a survey done by CDC in collaboration with FDA. It's the largest survey of infant feeding practices. This shows the effect of sugary drink intake in infancy on obesity at 6 years of age. And it's important to mention that about half of the children in this survey were lost to follow-up, so it's not a nationally representative survey. But you can see that in infants, that those who consume no sugary drinks had a considerably lower prevalence at age 6 years of obesity than those who consumed any sugary drinks. And as the age groups below show, that those infants who had introduction of these sugary drinks at less than 6 months of age had a higher risk than those who had sugary drinks introduced later. And you can see that early on it's 20%, later it's about 16%. Next slide, please. The other thing is that there is a significant consumption of foods which are pretty calorically dense, and those of you who know about the ultra-processed foods argument can see that these are the pre-sweetened cereals and the sweet bakery, which account for so much of the sweetened products that are consumed by age, are ultra-processed foods. The biggest contributor is sweet bakery, think cookies here, and then followed by pre-sweetened cereals. Those are not a huge contributor early on in the first year of life, but in the second year of life, they're a significant source of calories. And in the next slide, I show you the calories from sweetened foods by consumers. So in the last slide, we were looking at all consumers. So the group at 0 to 6 months was pretty small, but in that group, you can see that sweet bakery accounts for 200 calories per day, which is a real concern. But and later on that flattens out and it's matched by pre-sweetened cereal and sweet bakery, which together account for almost 200 calories a day in terms of their contributions to the caloric intake and potentially obesity. Next slide, please. So these are the feeding recommendations. The early identification of high-risk infants, that comes back to that first slide that shows that birth weight, excessive maternal weight gain during pregnancy, and tobacco use during pregnancy are risk factors for subsequent obesity. That the initiation and sustainability of breastfeeding is a significant factor, and that formula feeding is and the protein content of formula appears to be a risk factor for the subsequent development of obesity. Delaying introduction of complementary foods is an important strategy, and the current AAP recommendations for juice intake are that no juice is supposed to be given to children less than 1 year of age, and less than 4 ounces provided to children 1 to 3 years of age. Avoiding cow's milk before 1 year of age and responsive feeding are clearly indicated. The question is how to achieve these, and for that, we'll turn to Elsie. Thank you.
Thank you very much, Bill. Next up is Dr. Elsie Taveras. Dr. Taveras is Chief of the Division of General Pediatrics and Executive Director of the Kraft Center for Community Health at Massachusetts General Hospital. She is also the Conrad Taft Professor of Nutrition in the Department of Pediatrics at Harvard Medical School and Professor in the Department of Nutrition at the Harvard T.H. Chan School of Public Health. Dr. Taveras is a pediatrician and a childhood obesity researcher. Her main focus of research is understanding determinants of obesity in women and children and developing interventions across the life course to prevent obesity, especially in underserved populations. Welcome, Dr. Taveras.
Thank you very much, Kay. I'm going to go to the next slide. So while Cynthia covered prevalence and trends and Bill discussed dietary risk factors, my talk will focus on interventions implemented during pregnancy through age 24 months that aim to improve infant nutrition and prevent childhood overweight or obesity. And I'll also discuss gaps, opportunities, and observations of the published literature. Next slide. The interventions I'll be talking about today come from a few sources. In 2016, we published a systematic review of interventions implemented in the first 1,000 days for obesity prevention, And that review covered studies published from 1980 through 2014 and identified 34 completed studies from 26 unique interventions. Next slide. Since that review, we've seen a number of new interventions that have been published, and some of those are in an upcoming article by Ann Datillo that's in press, and others that emerged from a recent literature review. These identified 10 publications from 9 unique interventions. In March, there was also a series of systematic reviews from the USDA as part of the Pregnancy and Birth to 24 Months project, and I'll briefly highlight 3 of those reviews that focus on feeding. This isn't meant to be an exhaustive review, and I intentionally put the references and citations so that if anyone is interested in going back to this source, you'll find a lot more information about each of the representative interventions that I'm going to focus on today. Next slide. Overall, there were several commonalities across the various studies. Most of the interventions primarily work at the individual or family level, as opposed to a systems or policy level. Many of the studies are led by clinicians or health professionals. On average, the number of contact hours for the programs are about 8, from pregnancy to 24 months postpartum. Several interventions delivered a curriculum during home or clinical visits. The content of the curricula include feeding, with some also including sleep, and many encouraging a delay in the introduction of complementary foods and beverages. There are several emerging concepts in the more recent literature, including interventions that vary the form and content of infant formula, interventions testing repeated exposures to foods, and the influence of maternal diet during pregnancy and lactation on infant diet. Next slide. So let's start with a few representative examples of effective interventions. The first is Healthy Beginnings from Australia. Healthy Beginnings was an early life home visiting intervention delivered by nurses prenatally through 24 months after birth. While early results showed a lower body mass index among intervention participants, the effects were not sustained at age 5, and this highlights the important point of the need for sustained activities beyond an intensive intervention period to achieve sustained effects on obesity. Next slide. The Nourish trial focused on complementary feeding guidance and protective feeding practices. The intervention was associated with lower BMI among participants and a non-significant trend for lower child BMI Z-scores at ages 2 and 5 years of age. Next slide. The next 2 studies come from the research lab of Drs. Ian Paul, Jen Savage, and Dr. Leanne Birch. Many of you know that Dr. Birch passed away earlier this year, but was an incredible pioneer in early life nutrition, a mentor for many of us in this field, and she'll be sorely missed. Leanne was one of the first to also recognize the important dyadic relationship between infant sleep and feeding. Slim Time tested the hypothesis that interventions that promoted sleep as well as soothing strategies, other than feeding for soothing, could prevent rapid weight gain. Next slide. In a much larger trial, recently published by Dr. Savage and Paul, known as Insight, that also promoted sleep as well as responsive parenting and teaching parents to recognize hunger and satiety cues. Next slide. Also resulted and showed a reduction in rapid weight gain in the first year of life and a reduction in body mass index among participants at 3 years of age. Next slide. Sleep, feeding, and activity were also part of the Prevention of Overweight in Infancy trial that showed a lower odds of obesity among children ages 2 through 5 years. Next slide. Although some trials have not yet reported changes in growth, they have shown improvements in several feeding practices shown here, including continuation of breastfeeding, continuation of an increased prevalence of exclusive breastfeeding, a decrease in adding cereal to the bottle, a decrease in pressuring infants to finish their foods, and a decrease in sugar-sweetened beverage intake. Next slide. 2 recent studies have tested varying formulations of infant or follow-on formula and have found that the amount and form of protein in infant formula may affect satiety and energy intake and influence weight gain and body fat. Dr. Minella's study compared growth among infants randomized to a cow milk-based formula versus an extensively hydrolyzed formula and found more rapid weight gain among infants fed cow's milk-based formula from a month of age to 4.5 months of age. Next slide. And Dr. Wall compared cow's milk versus a reduced protein formula, follow-on formula, among 1-year-olds and found a lower body fat among those on a reduced protein formula. Next slide. A few reviews from the PB24 project are also of interest as they relate to improving nutrition and feeding. These include 2 reviews. The first by Maureen Spill, showing that repeated exposure to vegetables or fruits can increase infants' acceptability of the exposed foods, and the other showing some evidence that flavors introduced during pregnancy and lactation can also influence infant diet. Next slide. Finally, another review from the Pregnancy and Birth to 24 Months project looks at caregiver feeding practices and child weight outcomes and lends support to the responsive parenting focus of the INSIGHT trial and protective feeding practices for obesity prevention. Specifically, this review showed moderate evidence that providing responsive feeding guidance to teach parents to recognize and respond appropriately to children's hunger and satiety cues can lead to normal weight gain and/or normal weight status in children under 2 years of age, and moderate evidence that restrictive feeding practices are associated with increased weight gain and higher weight status, and that pressuring feeding practices are associated with decreased weight gain and lower weight status. Next slide. I'll end with just a few observations, gaps, and opportunities. The first is an observation from the literature review that few of the studies are actually beginning in pregnancy, and some of the studies that have begun in pregnancy are limited to those pregnancy interventions, including the LIMIT trial, for example. It's an opportunity, particularly given some of the more recent evidence showing the potential effect of improving and influencing maternal diet during pregnancy on later infant dietary intake. Few have also aimed to engage partners and specifically fathers, and another opportunity to leverage the social support system around mothers as they are feeding and in this very vulnerable period. There's a need for more interventions specifically that inform prevention and choices for parents who choose to feed their infants infant formula. While many new studies are emerging, including those by Dr. Minella and Dr. Wall, there's still a need for interventions among that population of parent-child diets. There's also a need for studies that examine and test implementation strategies to promote adoption, sustainability, and fidelity. So for example, I mentioned that several of the studies are delivered by intervention nurses, and it would be interesting to examine if the effectiveness of those interventions persists if they are delivered by other paraprofessionals, health coaches, community health workers, or even with the use of technology. In addition, many of the existing interventions have been delivered through home visits, which are logistically expensive, challenging and expensive. And so varying some of the strategies to deliver the existing interventions that have been found effective would be beneficial to those that are looking to disseminate and scale those interventions that have been found to be effective. An observation of the literature is that interventions that include sleep appear to enhance the standard food, activity, and breastfeeding guidance and improve effectiveness. It's an important dyadic relationship in those first few months of life between sleep and feeding and growth. And it appears from the literature that those interventions that really are including guidance for families on sleep hygiene really do appear to enhance the effectiveness of the interventions that go beyond guidance on feeding. Next slide. Several of the existing interventions have not shown sustained effects in long-term follow-up studies, and that brings up, as I mentioned earlier, an important opportunity and an important chance to think about how do we sustain effects through non-intensive activities after what in these interventions have been very intensive intervention periods. I would say that many of the interventions, as I mentioned, are at the individual and family level somewhat appropriately, but there's also quite a bit of opportunity to implement changes at a systems level, and those are lacking in the literature right now, with the exception of the study that Bill mentioned in his slide deck on the effects of the WIC food package and the effect that those changes have had from a systematic level on infant weight for length. There are also very few interventions that are utilizing community-based settings to deliver interventions. And finally, few interventions are working specifically to influence change and to support very low-income families, or that include mitigation of the social context or upstream influences on obesity, such as government policies or private sector practices. So I'll end there just by thanking again the working group that put together this presentation and for inviting me to present. Thank you.
Thank you very much, Elsie. We will now open the webinar to audience questions. Please type your questions into the Q&A box of the webinar, and I'll share them with our speakers. We already have quite a number of questions, so I'll start with a couple of questions for Cynthia. In particular, there was a question about the weight and height measurements that are taken in the programs, perhaps WIC programs, but maybe others. Often they use the well child exam for age 0 to 3. The question is, do we still need to measure those, and did that meet performance standards? And a related question is whether the difference between the prevalence of overweight in the WIC population and the Haynes population could possibly be due to measurement differences. Cynthia?
Yeah, that's a good question. I think that we have seen differences by income and obesity in many ages. So I think that the difference is probably real. There's the WIC data set is very, very big. And so unless there's a systematic bias, you wouldn't assume that that some error in the measurements would make that much difference to cause that difference between the national population and the WIC data.
Great. Okay. And another question actually could be for any of the speakers, and this has to do with the language that we use to describe weight and weight status and weight trends. So the question is, should we be referring to children with obesity or obese children with so much weight bias and stigma in the U.S.? How do we address real health concerns without doing harm? And I'll ask any of you to respond to that one.
Well, I'll take a shot at it, and then Elsie has some direct experience with patients. But I think that the term obesity is pejorative, and I think that we need to be sensitive to the use of that term, because even among adults, people will say, "Well, I have a weight problem, but I don't have obesity," or they say, "I'm not obese." So I think it's fairer to talk about overweight or on the road to overweight than it is to talk about obesity, particularly in young infants.
Thanks. Elsie?
And I would just add that we're very careful about using people first language. Bill has a wonderful editorial about that in publication that has been published, and I think it's more of a sensitive way to approach the conversation that we've done for many years in our weight management clinics, and that is quite a bit more appreciated by patients in our clinical interactions.
And I would just add that that's true in the literature too. It's really, the language is changing, and it has been changing for some time.
Great, thanks. Bill, there was another question about the definition of no sugary beverages or sugary drinks provided. The question is, did the survey count special occasions, less than one per month, as none, or was that counted?
I don't think that that survey asked about special occasions. The question was any sugary drinks. So I think it was really up to the parents to decide whether a birthday party and a sugary drink at a birthday party was counted as a sugary drink or not. It's a good question, but I know that that survey doesn't have a lot of detail about the circumstances.
Right, so perhaps there may be some underreporting of sugary drink consumption by caregivers. All right, another question for you, Bill, was regarding the issue of avoiding cow's milk until age 1. The question is, many formulas are cow milk based, and so what does that mean, and what can this person tell her clients about that?
Well, the fact that a formula is cow's milk based doesn't mean it's cow's milk. And the formula companies have done a really good job in adding nutrients that are trying, in which they're trying to approximate breast milk. But there's so many other components in breast milk that are not found in infant formula that I think it's an ongoing struggle. The ratio, and I haven't done a thorough review of this, but maybe Kay knows this, or Elsie, but the ratio of whey to casein in some of these formulas may be different. So it's not just that these formulas are diluted cow's milk. I think the fair way to say it is that they're cow milk based.
Yes, I would agree with that, and also emphasize that it's not just total protein that may be making a difference, but the composition of that protein, both in terms of whey and casein, and also in terms of other substances. Okay, I think I just got disconnected. Can anyone hear me?
Yes.
Okay.
Yes.
Right, so I've lost the video, but I will continue. I wrote a few questions down. One person wanted to ask Elsie to differentiate between restrictive and pressuring feeding practices. Elsie?
Oh, sorry. Hello?
Yeah.
Yes, Elsie. Did you hear my question? Shall I repeat it?
Sorry, everyone. So can you hear me?
Yes.
Yes.
Apologies, I'm not sure what just happened. Sorry, Kay, were you directing a question to me?
Yes, I was. Just to let everybody know, I've completely lost the video visibility here. I don't know why, but I wrote a few questions down. So I was directing a question to you, Elsie. If you could differentiate between restrictive feeding practices and pressuring.
Sure. I think in general, feeding practices that override an infant's own ability to regulate their intake are the types of feeding practices that we are talking about. Both restrictive, so overly restricting what infant is fed once they are on complementary foods and beverages, or pressuring infants to finish a bottle or finish the food in front of them. Both are feeding practices that in recent reviews seem to override an infant's natural ability to self-regulate their intake and are the risk factors too that are associated with excess weight gain in those recent reviews.
Great. Another question had to do with home visiting programs. These are of various types and run by various organizations. And could you comment on how those might be playing a role in preventing child overweight and the kind of messages that those programs include, and how do they intersect with federal and other types of programs?
So I think it's a very good question, and I see it as an interesting opportunity to leverage some of the existing home visiting programs that exist, but to also influence the curricula of those home visiting programs. I am sure that the existing home visiting programs include feeding guidance. I don't know to what extent some of the more recent that's emerging on feeding practices, on specific aspects of diet are disseminated across the existing home visiting programs. But I feel very strongly that we should leverage some of the existing infrastructure to deliver interventions such as the ones that I presented today. So some of the work that's happening through WIC is a terrific example of a systems level intervention that is really looking to not just change the food package, but enhance the nutrition guidance that's provided through WIC. I think the home visiting program offers another infrastructure that can be leveraged to scale some of the really terrific evidence that's emerging from the effective interventions you heard me present. Great.
Okay, so there are quite a number of other questions coming through. For Cynthia, and others may want to answer this as well, some of the differences that you were showing in terms of rates of child overweight varied among race and ethnic groups. Is there any information on the breastfeeding rates in those different groups that might help explain or understand those differences?
So among the infants and toddlers and NHANES, there were no differences in obesity prevalence by race ethnicity in what I'd shown. So I'm not sure that there were some differences in the WIC data, I believe, by race ethnicity, and then of course there are differences in the older children, and perhaps breastfeeding there may be some some influence, but we didn't look at that specifically in these analyses.
Okay,
so
thanks very much.
There are other, this is Bill, there are other data that show that rates of initiation and duration of breastfeeding are increasing across ethnic groups, but African American mothers still have lower rates of breastfeeding and lower rates of duration. The relationship of those practices to subsequent obesity is uncertain, but a concern.
Okay. Here's a question for Elsie. What specifically about sleep did the investigators find was helpful in increasing effectiveness of the intervention?
So there's a number of different components of the interventions that include guidance on sleep. I think one of the very first studies, and I talked a little bit about Slim Time. What Slim Time really taught families to do was, once infants were showing that they were growing well and didn't have any difficulty with their growth status around 3 weeks of age, there's a very clear set of guidelines for parents on how to promote an infant being put to rest, drowsy but still awake. Again, how to promote an infant's ability to self-regulate their own sleep, to fall asleep on their own without any external association that is needed if the infant falls or wakes up in the middle of the night, that then that external association is needed to fall back asleep. There's a lot of guidance in the sleep and growth literature about once an infant is on their growth curve and is growing well, the ability to reduce the number of feedings overnight that an infant is waking up for, and looking for other ways to soothe their infants. As infants are older, there's also quite a bit of attention to routines, bedtime routines and other routines to influence sleep hygiene and sleep quality.
Very good, thanks. This question, I think, is directed at Elsie, but others should feel free to jump in. It says, since the 2015-2020 dietary guidelines for Americans do not currently include children under 2, what measures are available to assess overall diet quality in this population?
So I'm very excited, actually, and Kay and I are on the USDA Dietary Guidelines Committee, that for the first time will be developing recommendations, reviewing the literature and developing recommendations for lactating women and infants birth to 24 months. In the meantime, I think there are recommendations, feeding recommendations, including the ones that Bill mentioned, that really can guide dietary intake and feeding practices among parents of infants birth to 24 months. Bill, I don't know if you want to add to that, but I do think it's an important change that the new guidelines will be including this important population.
I have little to add. I'm so glad that you and Kay are on that committee. But I think to the diet quality piece, I think that raises an interesting challenge. How do we assess diet quality in the 0 to 2 outside of whether they're fed breast milk or formula? I think that's a really interesting area that I'm looking forward to finding out what you guys conclude.
Great. Now, there is a question here about what we do with children who do become obese under 2. The question is, should children under 2 years old be identified as obese and interventions be considered? So I think this falls into the category of treatment. So perhaps Bill or Elsie, would you like to comment on that?
Well, Elsie, why don't you go ahead and I'll follow.
Sure. So first, I think is terminology. For infants under 2, infants and toddlers under 2, from the slides that Cynthia showed, terminology is important. We really don't call infant or toddler that age obese. Really, that's a definition. By definition, it's overweight. But then I think the second part of that question is, what do we do for infants? And I would say that one size does not fit all. It's not a very satisfying answer, but in the 20 years that I've worked, at least in primary care, and have worked with families of children who have either had rapid infant weight gain or have reached a point that their weight status is in the overweight range, it's really a matter of working with the family and together with their clinicians to try to understand what are the contributors to that excess weight gain. Sometimes it is related to feeding practices. Other times it is a matter of altering some of the diet and improving the quality of the diet. Other times it's reducing the amount of sugar sweetened beverage intake. But I caution by saying that it isn't one size fits all, and it requires a really careful conversation and almost investigation of what is contributing to the overweight status in that age group.
I would just add to that it really has to be individually based, as Elsie has said, and anecdotally, I had, when I was running a weight control program in Boston before moving to the CDC, I had 2 kids in a family whose mother was following all the breastfeeding guidance, who had excessive weight gain. I mean, these kids were chubby, and I worried about them. But when they shifted to a regular diet, they smoothed right out. So I think there's still a lot of stuff we don't know about what factors affect trajectories and how those might be modified by subsequent diet.
Very good. One interesting question was raised that concerns topics we really didn't have time to get into, and that is, are there any relationships between events early in life regarding mode of delivery, for example, cesarean section, breastfeeding, and the types of foods introduced and the development of the microbiome with regard to child overweight? We really didn't have time to get into this, but I'm wondering, Bill, if you would like to comment on any of that.
Well, yes, the data on delivery by cesarean section are a bit mixed, but there are a number of studies which do show that infants delivered by cesarean section have an increased risk of obesity, and that there is some suggestion that that's due to the difference in the microbiome between infants who are delivered vaginally, who pick up the mother's microbiome, versus those who are delivered by cesarean. And I can't remember, I know there's been one study in which infants were swabbed, infants delivered by cesarean section were swabbed with the maternal microbiome, and I think adopted the microbiome. But Kay or Elsie, you may know that better than I just don't remember the data.
Well, I saw some preliminary results from that study just a few months ago, and it looks promising, but I don't think the results are definitive just yet. All right, one perhaps last question regarding strategies. There was a specific question about whether anyone is testing a mobile app for parents to use in order to scale up interventions and advice regarding feeding of infants and young children and prevention of child overweight. Elsie, would you like to take a first stab at that?
Sure. So I would say there are a number of apps out there. I don't want to endorse any at the moment because I'm sure I'll be called out about it. But I would say it's an incredible opportunity. This is a population and a period of life where the parents and the professionals that work with parents are really hungry for advice, for tips, for guidance, for education. And I think it is one of the things that I mentioned in my talk, that there's such a need to understand, if we were to take the evidence that's emerging from these interventions and deliver it through technology, a mobile app, other virtual technology, are they just as effective? And so I think that there are very few studies that I have seen in the literature that are using technology or other modalities to deliver interventions, and is hopefully an area that we'll see more growth in the literature over the coming years.
Great. That's a wonderful topic to end on. So I would like to conclude the webinar now and thank everybody for joining us today. To stay informed about future events of the Roundtable on Obesity Solutions, please visit the website, which I believe is shown on the screen. Upon exiting, you'll be redirected to a short survey. And please take a moment to fill out the survey and let us know what you thought of the webinar. Your feedback is very important. A copy of today's recording and the slides will both be posted on the Roundtable's website within the next week or so. And with that, I'd like to again thank our planning committee, speakers, and all of you for participating. Have a great day. Thank you.